Our next speaker is Dr. James Fagin, who is professor of medicine at Cornell University and head of the division of subspecialty medicine and member of the Human Oncology and Pathogenesis program at Memorial Sloan Kettering Cancer Center. He gave one excellent talk in the morning, and he's going to speak now on targeted therapies for thyroid cancer, modulation of MAPK output. Jim?
Thank you, Yuri. What I'd like to do in my 30 minutes is to think a little bit more broadly about the role of MAP kinase in thyroid cancer, not specifically on necessarily just the differentiation aspects, but on other aspects of the biology, and I'll try and illustrate this in 3 different contexts. So, as many of you know, when we think about therapeutic approaches for thyroid cancer in a relatively simplified way, we think of 3 potential therapeutic targets. One is the tumor vasculature, and which has risen to the top in terms of its therapeutic relevance because of the development of multi-kinase inhibitors that, based on everything we know, primarily work through their inhibitory effects on vascular endothelial growth factor receptors and therefore decreasing angiogenesis. The second category are broadly what we could consider cell-autonomous targets. So these are essentially the mutant oncoproteins that drive the disease. As we've discussed earlier today, the BRAF mutations, the receptor tyrosine kinase fusions being the most predominant targetable lesions. And the third being the immune microenvironment. And it's no surprise to this audience that you all know that the area of tumor immunology has undergone an explosive development, and that many effective therapeutic targets in that context exist, not only checkpoint inhibitors, but also increasingly cell-based therapies. So I'd like to touch on these 3 areas, but I'm going to focus mostly on the latter 2, cell-autonomous targets and the immune microenvironment. So this slide was my first slide in terms of content in my previous talk, and just to refresh your memory about the various lesions in papillary thyroid cancer, the BRAF mutations, the RAS mutations, and the RTK fusions. And as I mentioned, there's not only genetic evidence that these primarily are signaling through MAP kinase, but also strong experimental evidence that this is true. First of all, BRAF V600E exclusively signals through the MAP kinase pathway. And the receptor tyrosine kinases and RAS mutant proteins, even though they can actually have a more diverse set of signaling pathways that they activate, it's key that in terms of therapeutic targeting, the MAP kinase pathway seems to be the one that appears to have a greater effect in tumor response. So this is not only true in differentiated thyroid cancer. So this is a study we performed a few years ago looking at the genotype of polydifferentiated thyroid cancers and anaplastic thyroid cancers. And I should, as a caveat, mention that the way we define polydifferentiated thyroid cancers is not the one accepted widely, in that we use very specific criteria. But having said that, most of the polydifferentiated thyroid cancers that would be considered by the Turin protocol primarily have RAS mutations, and some have receptor tyrosine kinase fusions. And if you use a broader definition, those that would be high-grade papillary carcinomas by some pathologists, those tend to have BRAF mutations. And this is also true for anaplastic thyroid cancers, with the difference that receptor tyrosine kinase fusions are underrepresented. They do exist. We did not detect them in this particular series of just over 30 patients. But again, we see this very significant impact of MAP kinase activating oncoproteins. And as has been discussed earlier by Dr. Nikiforov and others, when you start seeing advanced disease, you now also start to see mutations in other pathways, with the PI3 kinase pathway being very critical, particularly in anaplastic thyroid cancer, and then a number of others affecting chromatin remodeling genes, and mismatch repair deficiency on rare occasions. So if we now think about MAP kinase dependencies in thyroid cancer, let's try and break this down into three different areas. First, in terms of the dependency, in terms of tumor growth. So how does the activation of this pathway determine tumor size and burden? And specifically, how does inhibition of this pathway impact this? The second bit I've already discussed in my talk earlier today is on the differentiation state, but I'd like to illustrate one particular aspect of this based on preclinical studies. And the third is the immune tumor microenvironment. So first, in terms of the tumor size and burden, I mean, there's an important lesson that we can derive from looking at the results of clinical trials with the selective RAF kinase inhibitors, particularly vemurafenib, the first-in-class drug in this context, that was used in various phase 2 studies for both metastatic melanoma, which is where this whole field began, where the overall response rate in naive patients that had not been previously treated was usually found to be greater than 50%, and there's strong evidence that it also increases overall survival. So despite the fact that these effects are not durable, nevertheless, they have a significant impact on the disease. Now, surprisingly, in colorectal cancer, an early study found that only 1 of 20 patients, that's 5%, responded to vemurafenib, despite having the BRAF V600E mutation. And thyroid cancer is intermediate to this. The phase 2 trial led by Marsha Groves showed that the overall response rate in patients who were naive to prior treatments was 38%, and in pre-treated patients, it was only 27%. So you can see different degrees of response. So we became interested in this topic, also following up on this interesting observation from the analysis of some of the melanoma cases that were part of the first vemurafenib trials. And this study from Gideon Bolak showed that the extent of the inhibition of the MAP kinase pathway as measured by ERK phosphorylation in patient tumor samples, that those patients who had the best response in terms of overall decrease in size were those that had the greatest decrease in phospho-ERK. So you can see here that those that had the most reduction in tumor size were the ones where the pathway was inhibited to a greatest extent. So this, in a way, told us that the extent or the degree to which we inhibit this pathway is critical to attain an optimal tumor response. So based on this, we were interested to see if we could understand the basis for this. And so we did this study that was published now quite a number of years ago, but I think is an important illustration of this lineage dependency. So this is a study in cell lines from either melanoma, thyroid, or colorectal cancers, all harboring BRAF V600E mutations. So if you see here in the left panel, what you're looking at is the IC50, the minimal inhibitory concentration that suppressed 50% that reduced the number of cells by 50%. And you can see that in melanoma, the IC50 is less than 100 nanomolar. But in thyroid cancer, 5 of the 7 cell lines failed to respond even to 2 micromolar concentrations of the drug. In colorectal cancer, something similar, with clear evidence of unresponsiveness. And of course, if the tumors lacked a BRAF mutation, they don't respond at all. And here on the right panel, you're looking at the phosphodynamics of the inhibition of the MAP kinase pathway. And I would just have you concentrate in the middle panel here, which shows the phosphorylation of ERK, which is the downstream intermediate that is essentially reflects the activity of the pathway. And you can see here in melanoma, you treat with a concentration, a large concentration, 2 micromolar of the drug, and you totally suppress this pathway through 72 hours in every single cell line. By contrast, in thyroid cancers, you get an early inhibition of the pathway, followed by a robust rebound, as shown here. And this is also true for several of the colorectal cancer cell lines. So we were intrigued by this and interested to try and define what mediated this rebound. And what we found, and this, I won't go through this in great detail, but we used an unbiased approach to look to see if there was any evidence of upstream activation of receptor tyrosine kinases at this 72-hour period where we were seeing this greatest rebound in ERK phosphorylation. And these little dots represent phosphorylation of individual receptors. And here what you're looking at here, this is the HER3 receptor that at baseline was not active, but 72 hours after treatment with vemurafenib, there was an 11-fold increase in its phosphorylation. And here you're looking at a time course of activation of phospho-HER3 at 2 different phosphorylation sites, and also of phospho-HER2. And total HER2 and total HER3 were also increased. And this was not just a phenomenon that happened in a single cell line, but we saw it consistently among numerous cell lines derived from the thyroid. And this was not the case for melanomas, and it was not the case for colorectal cancer cell lines. And also, quite interestingly, what we found is that the ligand for HER3, which is neuregulin, is actually produced to a large degree by thyroid cancer cell lines. So here you're looking at neuregulin expression in the culture medium derived from these 4 thyroid cancer cell lines, whereas the melanoma cancer cell lines do not make neuregulin. And this is now looking at the secreted amount of neuregulin also in colorectal lines. So in neither of these, you saw this very high abundance of this transcript. And if you actually remove the transcript by a knockdown of neuregulin, you suppress the activation of HER3 and the activation of the MAP kinase pathway as well. So we then went on to try and see if you interrupt the activity of the HER3 kinase pathway, whether you sensitize these cells to vemurafenib. And without going through this complicated slide in detail, what you're looking at here is increasing concentrations of either vemurafenib or the pan-HER3 kinase inhibitor lapatinib, just to show that there is a very strong sensitization effect by blocking HER3 kinase and other members of this family. So this led us to come up with this model, which is what we believe is happening here. So when you have an activation of BRAF V600E, sorry, this seems to be moving by itself, we actually have a robust activation of the ERK signaling pathway. And under these conditions, these transcriptional repressors block the expression of HER3 and HER2. When you actually come in with either a RAF or a MEK inhibitor and you block the activity of MAP kinase, you de-repress the expression of HER3 and of HER2, which can now heterodimerize in the presence of the constitutive production of the ligand neuregulin. And this results in a reactivation of the pathway that happens through RAS and the wild-type RAF proteins that are not inhibited by these drugs. So we went on to do a clinical trial that is still unpublished, and I'm hoping that will be published soon, that showed very remarkable responses to this combination. So this is a phase 1 study with an expansion cohort of dabrafenib, a RAF kinase inhibitor, and lapatinib. And it was led by Eric Sherman at Memorial Sloan Kettering. And in the patients with differentiated thyroid cancer, this was the dose escalation of lapatinib, and this is the number of patients who were naive to prior treatments. And overall, you can see that the response rate and the durability of the response was very, very striking. It was about 60% across the board, very similar to the responses that we see with lenvatinib, but with much lower toxicity profiles. So let me now turn to the differentiation state. So the conclusion of what I've just shown you about the impact of MAP kinase inhibition in the context of metastatic disease that is, significant and a good justification for systemic therapies, is that it is possible to inhibit the tumor driver, but in order to do so effectively, you need to use combination therapies that interrupt adaptive negative feedback, primarily through receptor tyrosine kinases, and mostly by HER3 and HER2. Now, in terms of differentiation, a study that we did first in cell lines, it is illustrated here. And this is using the PCCL3 rat thyroid cell line that is quite well differentiated, and that we engineered to express conditionally the BRAF E600E oncogene in response to doxycycline. And that's illustrated here. When you switch doxycycline on into these cells 7 days later, you see this robust ERK activation and this suppression of the expression of the sodium iodide importer. If you now use increasing concentrations of vemurafenib in combination with this tool MEK kinase inhibitor, as you increase the concentration of these drugs and you attain a more profound inhibition of ERK phosphorylation, you get a dose-dependent increase in the expression of the sodium iodide importer. And if you look at the distribution of the reciprocal relationship between ERK phosphorylation and the expression of the sodium iodide importer, you need a very profound inhibition of the pathway to fully rescue the expression of NES. So we turn then to do this mouse models by James Nagaraja when he was spending time at Memorial Sloan Kettering. He's now back in Germany. And here what we wanted to do was to compare the first MEK inhibitor that we used, which was selumetinib, with this much more potent inhibitor of MEK, which is called CKI. It's a compound from Chugai in Japan. So I mentioned earlier that selumetinib inhibits the activity of MEK, but unfortunately does so in such a way that it can be reactivated by being in complex with RAF kinases, and therefore give you an inhibition of MAP kinase, but an incomplete inhibition. Whereas this drug is also an allosteric inhibitor of MEK and also complexes with RAF, but inhibits RAF kinases as well. So it induces a more profound inhibition of the pathway. So what we did is we treated mice with BRAF mutant thyroid cancers that we engineered. So these are genetically engineered mouse models. And what we looked at first, transcriptional markers of the MAP kinase output. And in mice, these are the two most robust ones. And what you can see here, we used increasing concentrations of the compound from Chugai and a maximal concentration of selumetinib. And at their respective maximal concentrations with selumetinib, we could get a 70% inhibition of MAP kinase output. And there was about an additional inhibition of 15% for a total of 85% inhibition when we used the compound from Chugai. But now if you look at the impact on this on differentiation genes, it was very remarkable. So whereas with the selumetinib, we attained a modest increase in the sodium iodide importer, very little on thyroglobulin, a little bit better on the TSH receptor. In the case of the Chugai compound that inhibited the MAP kinase more profoundly, we almost fully rescued the expression of NIS and got much greater restoration of differentiation overall. And this be translated into a much better response to therapy. So we used similar approaches as I discussed in my talk this morning. At baseline, we use an I184 PET scan, followed by treatment with the drugs, and then a repeat of the scan, and then treatment with radioactive iodine afterwards. And if you look at the overall uptake, the Chugai compound was markedly increased compared to selumetinib. In response to the treatment, here you can look at the overall tumor size over time. In blue is the animals were treated with a Chugai compound, and they actually had a very sustained inhibition and reduction of tumor size, whereas selumetinib at best gave a stable disease. And here are illustrated representative sections from the tumors of these mice, treated with either vehicle selumetinib or the Chugai compound, and stained here for phospho-ERK, as shown here, or cytokeratin. You can see there's only a vestigial remnant of the tumor in these animals that were treated with a Chugai compound prior to treatment with radioactive iodine, and the remainder of the tissue was essentially scar tissue. So, in the setting of differentiation, then, a restoration of thyroid differentiation and of RAI responsiveness is attainable in a large subset of RTK, RAS, BRAF-driven thyroid cancers. And there's more and more case reports coming out now of RET mutant patients treated with selective RET kinase inhibitors and showing increased differentiation. The same thing for ALK mutant patients treated with ALK inhibitors or TRAC inhibitors for NTRK mutant cancer. So this seems to be a broadly applicable concept. Second is that attainment of this therapeutically relevant RAI avidity requires profound inhibition of the pathway, for which understanding how cells adapt to these targeted therapies is really essential. And as I mentioned above, that thyroid cancer cells are prone to develop these adaptive resistant mechanisms quite robustly, much more so than melanoma. And mechanism-based combination therapies will likely be required. So to close, I'd like to say a few words about the impact of MAP kinase on the immune tumor microenvironment. And this is a sort of work that we are currently sort of actively engaged in. I won't show you much data, but more in terms of some conceptual thoughts and hypotheses that we can only back with data in part, but that we feel pretty confident that we're on the right track. So first, this is the striking data from clinical trials. So if you look at the two studies that have been done with combination therapies, with a RAF kinase inhibitor and a MEK inhibitor, one of these was done for papillary thyroid cancer, and it combined dabrafenib and metinib. And as you can see, the response rate was 33%, no better than dabrafenib alone. However, in anaplastic thyroid cancer, and I'm sure Maria will be talking about this in detail, the response to vemurafenib was 30%, but the response to the combination was a remarkable 33%. And this has been totally transformational for how we approach patients with BRAF mutant anaplastic thyroid cancer. And she will talk about how this has enabled totally novel approaches, including neoadjuvant therapy and so on. And what we were intrigued by is what explains this totally paradoxical result, where a tumor with much more tumor burden, far more aggressive properties, many additional mutations that lie outside the canonical MAP kinase pathway, and despite this, we see this spectacular response rate. So, first thing to be aware of is that the MAP kinase output in anaplastic thyroid cancer is actually greater than that in papillary thyroid cancers with the same mutation. So here are two different mouse models. One we created, one that David McFadden created when he was in Tyler Jack's lab, and where they measured the MAP kinase output and compare it to papillary thyroid cancer. And in these two anaplastic thyroid cancer models, the MAP kinase output was greater. And if we look at in human thyroid cancers based on RNA-seq data, this is also true. And I noticed in a slide that Cesar presented this morning, where he was illustrating MAP kinase output based on histology, all of the anaplastic thyroid cancers on the high output side. So this is very much what we see. So how to explain this? Well, in response to oncogene activation, be it by RAS, which were the first examples of these experiments were done, or BRAF, these oncogenes, when they constitutively activate the pathway, they induce some degree of genotoxic stress. And that results in cell cycle arrest and often leads these cells to senesce. And they do so through the activation of the p53 pathway, which is an autonomous tumor suppressor, which essentially is why, for instance, we all live with small nevus, which contain BRAF mutation, and yet they very rarely transform to melanoma. So they have the BRAF 600E mutation, but it by itself is insufficient to induce tumor growth because it activates this senescent response. As part of the senescence, there's also an activation of a number of cytokines that happen and that are produced by these senescent cells. We no longer have p53 function because of loss of p53. This secretive phenotype is even more massively induced, and that would be pro-tumorigenic and change the tissue microenvironment. And if you look at data that we collected, here we're looking at the markers of this secretive profile. This is called the senescence-associated secretive profiles, which is a number of cytokines that are associated with that senescent response. In blue are normal thyroid tissues, in green, papillary thyroid cancers, and in red, anaplastic thyroid cancers. And these are examples of cytokines that are activated by activation of BRAF and suppressed when you switch BRAF off. So we do see this toggling up and down of cytokines induced by BRAF. So now let's look at the immune composition of papillary thyroid cancers as compared to poorly differentiated and anaplastic thyroid cancers. This study that we did but also that confirmed by Anna French in collaboration with our group, where we sent some tissue microarrays to her for her to do her stains and her analysis. And what you're looking at here specifically is staining for M2-like tumor-associated macrophages or M1-like macrophages and T cells. And as you can see, papillary thyroid cancers are relatively immunologically poor. They have very few immune cells, whereas poorly differentiated thyroid cancers are intermediate. And as we reported many years ago, it confirms beautifully, anaplastic thyroid cancers are totally loaded with myeloid cells, both myeloid-derived suppressor cells as well as tumor-associated macrophages. And they're also quite rich in T cells. But we believe that these T cells are unable to have effector properties for a number of reasons I'll explain in a second. So the other thing we wanted to validate is the mouse models that we've created of thyroid cancer, poorly differentiated thyroid cancer, and anaplastic thyroid cancer actually are good avatars of the human tumor. So for this, we used RNA sequencing, and we were able to immune deconvolute this in association with Tim Chan's group, and that can actually give you an estimate of the composition of different immune cells within the tumors. And you can see that the human and the mouse anaplastic thyroid cancers have very similar content of these different immune cells, which we've then confirmed as well by multiplex immunofluorescence. So this is my closing slide in terms of what we believe might be happening. So this is the experience with dabrafenib and trametinib. We have a 33% response rate in differentiated thyroid cancer. These are immunologically poor, weak, devoid tumors with a low tumor mutation burden and an intermediate activity of the MAP kinase pathway. By contrast, in anaplastic thyroid cancer that have a high tumor mutation burden, their MAP kinase output is increased. We believe that results in an increase in cytokine production, which in turn recruits immune cells into the tissue microenvironment. So what does MAP kinase inhibition do? Well, we've shown you data, and we've confirmed this in mice, that when you block this pathway, decrease tumor cytokines, and that results in a depletion of macrophages and MDSCs, which actually dampen T cell activation. So when you suppress the production of these cell types, you enable these T cells to respond. The second thing that happens is you have an increase in interferon gamma signaling, which allows antigen presentation by the tumor cells. And this combination of effects allows for T cell cytotoxicity, which we believe is what is unleashed by MAP kinase treatment in the context of anaplastic thyroid cancer. And of course, this remains to be proven, but if correct, combination with approaches that would increase this further, like checkpoint inhibitors, should give an even greater response. So, in conclusion, I'd just like to again, thank my collaborators, in particular the work on anaplastic thyroid cancer. Jeff North, who is now, at the Cleveland Clinic, did an enormous amount of work in this space, and he is largely responsible for many of these insights. And then, of course, my collaborators in pathology, Ronnie Hossain and Bin Shu. And thank you for your attention.